Thanks, and thanks very much for the invitation to speak in this session. So I'm a genetic counsellor. I'm not a medical clinical person, and I've spent a lot of time in research, and I'm going to talk about some of the stuff that our team has been working on for the past 15 years. So to give you an idea of what we do, I'm going to present to you a couple of our families that we see pretty regularly in our clinics. This is a lady who never unwell a day in her life, no significant pre-existing conditions, is stay-at-home mum with her 2 young children, and she unfortunately has a cardiac arrest and dies sometime mid-morning, and her husband doesn't come home till later in the afternoon but finds her deceased, and obviously she's unable to be resuscitated. So we met the family a few months later when the post-mortem had come back undetermined, so no cause found. This is another family. This was a 17-year-old boy who was an elite level cyclist, participated in competitions really frequently, and one weekend doing some training at the velodrome has a cardiac arrest. His father's there, sees him come off the bike and knows straight away that something's not right. There's a defibrillator there almost immediately, but they're unable to resuscitate him and he passes away. We saw the family a few months later when again the post-mortem was undetermined, and the father, who was there at the time, had some fairly significant psychological issues from that, was unable to drive because his hands would shake too much, was unable to sleep because all he would see is that. And so that's a family that's become fairly well known to us. Another family, similar story. 22-year-old son still living at home, had been out the night before with some friends. His mum let him sleep in a bit the next morning. He didn't have to be anywhere. At about 2 o'clock, she went into his room to check on him and found him deceased in his bed. And she runs a family daycare, but she now can't manage the anxiety of having other children asleep under her care. So she's obviously had to change quite a lot of her life based around this. So sudden cardiac death is tragic, and when it happens in a young person, it's a really high profile, tragic, just devastating event. We see families like this in our clinics every week, and every single story still just really, is quite difficult to hear. We've done quite a lot of research in this area, and this is a paper that we published a couple of years ago, for the first time doing a prospective nationwide study of all sudden cardiac deaths between the ages of 1 to 35 years across Australia and New Zealand. And we showed that the incidence was about 1.3 per 100,000 individuals, which is not common, thankfully. But the other interesting thing was that the most common finding at post-mortem is nothing. It's unexplained and undetermined. And we think that in the majority of those cases, they're probably inherited arrhythmia syndromes, which you would only see in a living patient. So we run the Hypertrophic cardiomyopathy and genetic heart disease clinics at Royal Prince Alfred Hospital, and we're also part of a larger program, the molecular cardiology program, which is run by Professor Chris Samsarian, who's pictured here. We take a multidisciplinary approach to care, so genetic counsellors are in our clinics. We're trying to establish links with psychologists. We often speak to the forensic pathologist. We've got a lot of research happening, and we see families with lots of different inherited heart diseases and the families after a young sudden cardiac death. And the other main contact that we have with patients is via the Australian Genetic Heart Disease Registry, which I set up during my PhD, and we aim to enrol every single family in Australia with an inherited heart disease. And we're not ambitious much, but we're hopefully trying to get there. So hypertrophic cardiomyopathy is the most common condition that we see, and fortunately most of our patients who we see are living and they have this condition. And I won't go into detail except to say that most of these conditions are inherited in an autosomal dominant way. So, for example, this is one of our families, and you can see that there's the black symbols are the individuals who are affected. In this particular family, there's a lot of affected people. Some of them have died suddenly. The one boy there at the age of 16, and others have died from heart failure, and others have required a cardiac transplant. This is a kind of more severe family. All of our families aren't like this, but gives you an example of the inherited nature. So cardiac genetic testing has been really helpful in a lot of these families. And when I first started over 15 years ago, what we could do with genetic testing was, we could test maybe 5 genes that might take 2 years, and it was all done in research. Now we're routinely consenting patients to have exome sequencing, which is where we sequence all 22,000 of our genes. And now, because of an Australian Genomics initiative, I'm routinely consenting patients for a whole genome, which is, beyond anything any of us ever imagined that we'd be able to do. And the basic principles of genetic testing in these inherited heart diseases, and in any of the inherited diseases, is that first we have to find a proband, so someone in the family who's definitely affected. And in that person, we take a DNA sample and we screen through a list of genes that we know to be associated with that particular condition. If we're able to find a genetic variant that we're fairly confident is the cause of disease, we can use that as a tool to test for the presence or absence of that variant in other asymptomatic relatives. And that can tell us if a person's positive, that can mean that they might need to continue to see a cardiologist in the coming years, and that their children have a 1 in 2 risk. And if they're negative, they can be released from all future clinical screening, and their children are not at risk. So it's a fairly powerful tool for managing the families. And the tricky thing is, it sounds really simple and great, but this is a complicated process. And the reason it's complicated is because as we've learnt more about genetics, we know that everyone carries rare changes in their DNA. So we're looking for one needle in a haystack, essentially. And the challenge is there's lots of needles, that look important. And so we have to be really careful to make sure that we find the correct variant, because if we don't and we start testing family members and releasing them, then that could be potentially a big issue. So it becomes like detective work, and this is probably one of my favourite parts of my job, because we have to build a case as to whether this variant is the cause or not. And I'm not going to go into any of the details, but if we think that it's causative, then we will call it likely pathogenic or pathogenic. If we think that it's not, we'll call it likely benign or benign. And if it's somewhere in the middle, then we say it's uncertain. And that's this sort of annoying category where we don't really know where to put it. And to give you an example of the issue that this uncertainty can cause, this is a study that my PhD student, Charlotte Burns, published a couple of years ago, and we looked at what happens if you do a really targeted test of just a couple of genes compared to, at the time, a fairly comprehensive test looking at 46 genes. And the pickup rate of the actual cause didn't really change. But the pickup rate of these uncertain variants increased dramatically and actually outweighed the diagnostic yield. So the more genes you test, the more uncertainty you find. This is another bit of data that I pulled out recently for a paper, and I looked at 24 commonly used genetic tests that are commercially offered for hypertrophic cardiomyopathy. And across those 24 panels, these are from all different companies, across these panels there were 162 unique genes, and only 23 of those genes were present on more than half of the panels. So enormous inconsistency in what genes are being tested depending on what lab a clinician sends a test to. So there's massive amount of uncertainty in this process, and lots of different ways without expertise where you can introduce harms to the patient. And so being aware of that, I think, is a really important thing, where we need to, always be mindful that we're not causing more harm. So the other aspect that I wanted to talk about of our work is the impact on the psychological well-being of our patients. And, from my first slide where I described those families, I'm sure you can appreciate that can be fairly significant. And this has been an area of my research, especially over the last few years, in trying to understand what the impact is for these families that come in with an inherited heart disease. We know that just having a new diagnosis can lead to anxiety, having an implantable defibrillator and having shocks can lead to anxiety. Genetic testing seems to be fairly well accepted, but having a family history and your experience with the disease, so if your experience with the disease is that your 15-year-old died suddenly, then you're going to be really fearful that anyone else in the family who has the condition is going to have the same outcome, even though all up it's actually a fairly rare event. And so in my time working as a cardiac genetic counsellor, I had 1 week of training on grief during my master's, during my grad dip. And I've had to become an expert in dealing with grief. And as we do, we learn these things. So grief is a normal response to the loss of something. And, it's experienced differently by people, and it's a way of adapting to a new reality. And most people will be sad and upset, but eventually they'll come out on the other side. And this is a really nice quote that I just wanted to read out that really nicely summarizes it. So the reality is that you will grieve forever. You will not get over the loss of a loved one. You will learn to live with it. You will heal, and you will rebuild yourself around the loss you have suffered. You will be whole again, but you will never be the same. Nor should you be the same, nor would you want to be. And that's the principle, really, especially when we're dealing with these families where there's been a young, sudden death, that I think is really important. But in a proportion of the population, this grieving process gets stuck. It stops, and people get stuck in this persistent yearning, where they can't imagine their life going forward without that person. And it's a really dysfunctional way to be. In the general population, it's estimated to be about 7%, and it requires treatment with a psychologist. It is not something that you just get over. So we performed a study where we looked at about 100 of our at-risk relatives who were coming to us after the sudden, unexplained death of a family member. And what we found is that about 20% of these family members had what we would call prolonged grief. And this was on average 6 years after the death of the individual. 36% of the mothers had prolonged grief, and 42% of the relatives that witnessed the event or discovered the deceased body had prolonged grief. So quite high, if you imagine. Remember that I said 7% of the general population. Post-traumatic stress is another big issue. You remember from the first slide I said the father couldn't drive because his hands were shaking too much and would have visions of the event when he would try to sleep. We also looked at that. 44% of the participants reported clinically significant post-traumatic stress symptoms, 59% of the mothers, and 69% of the relatives that were there that witnessed the event. So we set out to look for factors that might predispose people to requiring psychological support after a death. And basically what we decided is that everyone, all of the first-degree relatives, need psychological support following a young, sudden cardiac death. And so when I analysed this data, the very next day I saw a family and it changed the way that I spoke to them. And now at every single family we see, we try to break down that stigma of the need for a psychologist, and we really help them to try to connect with one who will help them. We've since done a more formal needs analysis, and this is some work that a clinical psychology student, Christy McDonald, did, and we found that medical needs were the most important needs for these families, but we also found that the psychosocial needs were the most unmet. And that's not just a psychologist, but it's psychosocial support from their family, from the community, from friends, and more formal avenues. So the multidisciplinary model of care is really important, and we really advocate that this is the way that most of these families should be looked after, because their needs are fairly complex and we don't understand everything about these families. So research is really, really important. So in summary, the clinical, genetic and the psychosocial aspects of care are important. Cardiac genetic testing is a really rapidly evolving area, and our knowledge is continually changing, and there's a lot of inherent uncertainty, and so we have to be careful when we're speaking to our patients that we can help them to understand that. The implications for the family can be really significant. They can be significant when we get it right and really helpful, and they can be really significant when we get it wrong. And this is all best performed in a multidisciplinary setting with a high level of expertise. Thank you.